Okay. Again, thank you very much for coming and to be with us here, and congratulations for the excellent presentations. Esto, aunque parezca un poco lacónico, es lo que hay. Más me parece que es imposible. Entonces, en el quirófano ya están preparados para dentro de 5 o 10 minutos, pero el doctor Coleman, que tiene mucha experiencia docente, es el responsable de docencia en el servicio de urología en Memorial, siempre nos invita a que hagamos buenas discusiones y de contenido muy práctico, de manera que si alguien en la sala quiere hacer alguna pregunta directa a alguno de los 3 participantes, adelante. Y si no, yo invitaría al doctor Coleman a que diera su opinión sobre las presentaciones y los criterios que se han manejado.
Well, first of all, thank you to the organizers for inviting me to come, and thank you to everyone for coming out today. But I think all 3 presentations today brought up some very significant issues in the field in terms of how we manage patients with very early prostate cancers, and how the management strategies that we're developing for prostate cancer are changing rapidly along a parallel course with changes in imaging technologies and our abilities to identify small tumors and new treatment options for managing these patients. So I have a question for Dr. Allen, which I think her presentation was very nice in demonstrating the differences in the new MRI techniques and scoring systems that are there. One of the issues that we're seeing is with patients being followed on active surveillance. And we are looking for techniques to be able to quantify and qualitate the changes that we see over time. The tumors that are getting larger, tumors that are getting more aggressive. Right now we rely on our biopsy strategies that Dr. Emerton presented very nicely, but can we move to a quantitative system with MRI that can show us changes in volume, changes in aggressiveness in a different way outside of the PIRAD system?
That doesn't work.
This one's very loud. So.
It is very loud. Absolutely. I mean, that's the next thing. And one of my colleagues, Caroline, has been doing some work getting people together to look at the whole active surveillance and the nomenclature and how we talk about it so that we're all talking about the same things. And certainly we're looking at a system for seeing what we measure on MR and on what sequence we measure it. At the moment, PIRADS is a diameter-based system, whereas we need to go to a volume-based system for active surveillance. What we don't know is what change in volume is significant. We do know, because we've done the work, that lesions are very stable, can be very stable over time. And we also know that the lesions don't change from MR to MR within a sort of month or 2. So we know that we have a baseline where the MR doesn't change. So we looking at a year or 2 years down the line, we need to see whether it's going to be a volume measurement, whether it's going to be a diffusion. There's some really interesting new diffusion sequences, looking very carefully at tissue density and seeing whether we can predict an increase in Gleason score, which might take that patient off active surveillance. And I think that's right. It's a whole different nomenclature that we need to use. We can't use the PIRAD system for it, but we are coming up with, and one of my colleagues, Mark's colleague, Caroline Moore, is really instrumental in trying to get people together to set a standard. But we're going to need to have it validated. And at the moment, we don't have that validation. We know what we can measure currently, but it will have to be in a cohort where we are able to validate it properly.
Can I comment? It's a fascinating question. In fact, one we were discussing yesterday with some of the residents, and it goes to the heart of what we mean by progression. And when you see a tumor, it's obviously progressed in the past to get to the volume that it has. The information that's missing is the time over which that happened, and the nature by which it happened, of whether it's a continuous process or indeed an episodic process. And because most tumors' lives are cut short by treatment, we've been unable to ascertain in the past the natural history of progression. There are only two places in which we can do it, and that's the prostate and the kidney. They're both urological tumors, so I think in terms of understanding the biology of the disease, CT, possibly MRI, and MRI for kidney, and MRI in prostate, we're going to be able to get access to this. One thing that is coming, that is quite clear now, and this goes to the heart of active surveillance and what it is that we'll be monitoring in the future, is that once you see a lesion, it's almost invariable that there's some secondary pattern 4 in that lesion. And so our active surveillance is going to change. Historically, it's been no lesions and low-risk Gleason 3+3, but I think increasingly we're going to watch these smaller lesions with well-characterized secondary pattern 4 and maybe monitor the proportion of 4 that exists over time. And I think, I'm going to stop in a minute, I could go on forever about progression, but what's progressing? You know, is it the cancer cells that are changing? Is it the desmoplasia? Is it the stroma? Is it the normal tissue, the blood supply? All these changes that are happening, to what degree do they relate to aggressivity and propensity for metastases?
I think that's an important question, because I think with MRI we don't really even know what we're measuring when we're looking at MRIs. And it may be stromal changes, it may be vascular changes in tissues that tell us more about what's going on here. And it also brings up the question of what new imaging modalities outside of MRI are going to be developed in terms of different types of PET imaging and so forth that may be more informative in terms of some of those biological changes that are occurring inside of cancers. So to ask a question regarding some of the presentation you gave earlier about low-risk cancers and overtreatment for cancers. What we're seeing is a massive shift towards active surveillance around the globe. We're seeing it strongly in the United States. It's been shown in Europe. What are your thoughts in terms of what this may hold for the future of patients as we see a swinging of the pendulum in the direction more of active surveillance? Are we going to be managing the downstream effects of this in a different way in the future?
Bueno, yo creo que los efectos en algunos países ya se están eliminando. Los países nórdicos, por ejemplo, tienen una gran tendencia a hacer vigilancia activa de una manera muy ostensible. Incluso en la categoría de muy bajo riesgo en Suecia se habla del 90%, etc. Yo creo que el futuro va a estar muy condicionado por aspectos socioculturales. La incertidumbre del paciente ante estas situaciones y la forma de ver la enfermedad, yo creo que es bastante determinante y es muy diferente de unos países a otros. Yo hace poco, de una información del Instituto del National Health en Estados Unidos, leí que solamente se mantienen en vigilancia activa el 25 o 30% de los pacientes con el paso del tiempo. Entonces yo no sé realmente a largo plazo cuál va a ser el impacto real para aceptar estos datos. Lo que parece evidentísimo, y más en vuestras manos, que tenéis mucha experiencia, es que la resonancia es determinante, ¿no? Alguien decía que va a ser el GPS de la próstata. Te va a decir... Entonces, yo no sé, yo creo que los aspectos socioculturales van a ser determinantes, porque el otro lado, que son los biomarcadores, hoy por hoy son carísimos, no son accesibles en los sistemas habituales, públicos, etcétera, y no creo, no sé cuál es tu opinión, Marc y John, que solucionen el problema, de manera que vigilancia activa y basada en imagen. Y luego, a nivel cultural en cada sitio, pues...
If you play forward, it's not inconceivable that a period of surveillance may be a necessary prerequisite to therapy, unless, of course, you've got T3A, T3B disease. So PROTECT, only 1% of the patients in PROTECT died of prostate cancer. It's a really stark, this is a median follow-up of 10 years. And it may be actually that when you diagnose somebody, we just watch it for a while. And the people that you treat are those that progress, either their PSA rises or the volume of the lesion gets bigger, because it's very hard to keep watching those individuals. And that might be a form of triage to help us address over-treatment in the future. But that I think is starting to play out.
El quirófano manda y los pacientes están ya esperando para los procedimientos quirúrgicos, entonces vamos a hacer la presentación de los casos y conectamos con quirófano. Luego tendremos oportunidad de seguir discutiendo.